All right. Well, we are 5 minutes past the hour, so I really do appreciate everyone for joining us here today on this Sunday. I'd like to introduce Dr. Leon Ptaszek. He is the Assistant Professor of Medicine at Harvard Medical School, Cardiac Arrhythmia Service, Mass General Harvard. So today he'll be talking to us about the evaluation of wide complex tachycardia. If you want to take it from here, I really do appreciate you, Leon.
Sure, I'm happy to join. Thanks for the invitation. Always nice to join up and have a conversation. You're catching me while I'm covering the service, so I apologize in advance if you hear a page go off and I have to respond to it. So today's session is focused on the evaluation of wide complex tachycardia, and rather than having this be a purely didactic session, I was hoping that this could be uh, a partially interactive session, or as interactive as you want it to be, uh, and to discuss in a very practical manner one patient uh, who was treated at MGH with wide complex tachycardia, that the treatment of which included a lot of challenges associated with evaluating people who present in this manner and all the different things that you have to worry about. So rather than being a broader approach to arrhythmias, this is just a very practical case presentation. And so the objective for today's session is just the following. I'm just hopeful that at the end of the session, participants will be able to utilize clues on 12-lead ECGs to distinguish between the different possible causes of a wide complex tachycardia and to recognize the challenges associated with the evaluation. So the patient we'll be talking about is the following. It's a 68-year-old man known to have paroxysmal atrial fibrillation and known ischemic cardiomyopathy who presents with lightheadedness. And his history is also noteworthy for high blood pressure, diabetes, and obesity. When he came in, uh, he was noted to have vital signs that were uh, markedly abnormal. He did not have a fever, but his blood pressures were on the low side, 96/60. He was found to have a rapid and regular pulse at 140, and he was breathing at a normal rate, but on exam, he appeared unwell. He was diaphoretic and he was not tiring out, but he was clearly working hard to breathe. His JVP was not markedly elevated, and exam of his lungs revealed good air movement with some scattered crackles, but no obvious signs of fluid overload. And on heart exam, there was a regular S1, S2, but no S3 or S4, and no rubs or murmurs. His abdomen was benign, and he has some trace ankle edema, which the patient reported was not a new finding for him. And in the ED, because he's presenting with rapid tachycardia, an attempt was made to go through the most recent non-invasive studies done for the patient, all of which had been done um, not too long before he had come into the hospital. So, as we had mentioned, he did have a known ischemic cardiomyopathy. His ejection fraction was mildly reduced at 45%, but he didn't have any left ventricular hypertrophy. He did not have any wall motion abnormalities. And he had no other significant structural heart disease. Specifically, he had no hemodynamically significant valvular disease. A stress test also done in the recent past showed a slightly lower left ventricular ejection fraction, largely due to the properties of the test, in that the patient had a small inferior infarct that was transmural, which led to a proportionally larger drop in the measurement of ejection fraction by stress testing. And there was no obvious reversible perfusion deficit, so no obvious ischemia. And this is the tachycardia he came in with. Um, And I think just as a general rule, when you're seeing somebody who's got a wide complex tachycardia or a tachycardia of any type, I think it's uh, common and perhaps easy to get stuck looking at the tracing and perhaps lose sight of the fact that we're there to treat the patient. And so no matter what the rhythm is on the screen, I think you're always well served to take a look at what the patient is doing. And in this circumstance, here's this wide complex tachycardia at a rate of 140, and the vital signs associated with this tachycardia were exactly what I showed you earlier, in that you had an uncomfortable patient, mildly hypotensive, but not coming in obvious shock. He's not coming in pulseless, etc. So always focus on what you're seeing, because remember, when you're thinking about how to treat tachycardias, um, you have not just options of medications to give, but also the option of a cardioversion. And as you go down this pathway of trying to figure out the different explanations for a wide complex tachycardia, meaning, is it a supraventricular tachycardia with aberrant ventricular conduction versus a true ventricular tachycardia? Even if you can't figure out which one of the two it is, if the patient is markedly hypotensive, if they're going into shock, etc., you need to think about cardioverting them. Whereas if you've got somebody who is talking with you normally, looking comfortable, and uh, does not have any marked hypotension, it's a situation in which you can think about milder medication-based approaches to start. So as you take a look at this rhythm, um, I want to ask you a question about it. So question is this: what are the possible explanations for this rhythm? Is it a supraventricular tachycardia with aberrancy? Is it ventricular tachycardia, or could it be both? And I mentioned earlier, the hope is that this can be an interactive session. But again, I'll make it as interactive as you want it to be. And I'm not going to call on people, and I'm not going to demand that somebody responds to these questions before moving on. So if nobody else has any thoughts about this, I'll just move on to the next step and say that the answer to this question is any of the above. Both supraventricular tachycardia with aberrancy and ventricular tachycardia are possible explanations for this, in part because of the following. As you go across, uh, one question you can ask yourself is, do you see a P wave? Is there evidence that this is a sinus tachycardia or an atrial tachycardia? Um, well, as you go across, it's hard to say that there's definitive evidence of a P wave in all cases, although every now and again you'll see some notching either on the distal end of the QRS complex, or sometimes you'll see a notch just before the QRS complex. And the timing of this notch, which is only intermittently visible, varies with respect to the QRS complex. And so, although this may represent supraventricular activity, um, given the irregular or the non-constant relationship with the ventricular uh, rhythm, it's tough to say that this is an arrhythmia that's being driven by uh, atrial or supraventricular activity. And like we talked about earlier, this is clearly a wide complex tachycardia. It's negative in the inferior limb leads, so the axis is going from the bottom to the top, possibly consistent with ventricular tachycardia. But you see that there's a fairly well-formed QRS complex, at least in the anterior precordial leads, which is the kind of thing you may expect if this is either supraventricular conduction with supraventricular tachycardia with aberrant conduction through the ventricles, or possibly, if it is truly a ventricular tachycardia, a focus that's coming from relatively close to the conduction system. So all these uh, possible explanations are in play, meaning this could be supraventricular tachycardia with these atrial notches, possibly atrial notches. Nobody knows what to make of them. They're irregular. They could even be artifact, or is it ventricular tachycardia? So as you're going through, it's good to look at the QRS complex in detail to assess whether or not you see any uh, evidence in the waveform of the QRS complexes that are more suggestive of ventricular tachycardia versus supraventricular tachycardia with aberrant conduction. And I'm sure you're all familiar with the Brugada criteria, and this next question intends to just review what is in the Brugada criteria for identification of ventricular tachycardia. So the question is just which of the following are included in the known Brugada criteria. Number one, is it absence of an RS complex in the precordial leads? Number two, is it an R to S interval greater than 100 milliseconds in at least one precordial lead? Number three, is it AV dissociation? Number four, is it morphology criteria, meaning a right bundle branch block, meaning positive in V1, or a left bundle branch block, or negative in V1? Or is it all of the above? And the answer here is, of course, all of the above. All of these things are listed as being part of the Brugada criteria, meaning if you observe these things, the pretest probability that the arrhythmia that you're looking at is more likely to be a ventricular tachycardia. So again, although we're talking about how to interpret a rhythm here, always keep it in context, always be treating the patient and not the EKG. And so just two things I would ask you to do or remind yourself to do in what is admittedly a stressful situation when you get a patient who presents in this manner. Number one is assess the patient's blood pressure and overall clinical status. If they're unstable, go ahead and follow ACLS criteria and consider the cardioversion. And number two, only after you assess whether or not the patient's stable or unstable and whether or not you should be cardioverting them straight away, only after that would you spend more of your bandwidth on determining the mechanism, meaning SVT with aberrancy versus VT. And here, rather than going right to the Brugada criteria, I would ask you to first look at the ECGs or perhaps even the telemetry uh, that's live to look for fusion beats, because although we talk about Brugada criteria as being something that can be very helpful in determining whether or not a rhythm represents ventricular tachycardia, you've got to know that all these different items in the Brugada criteria, like we had talked about previously, the RS complex, the RS interval, the AV dissociation, and the morphology criteria, these are all indices of suspicion, right? That what you're looking at is a ventricular tachycardia. You can make an argument that the only true proof is if you see fusion beats, meaning evidence of beats that are due to manifest ventricular sourced conduction versus collision of wave fronts from the atrium and the ventricle, leading to different types of morphologies, hence the fusion beats. So let's go back to this case and ask ourselves, do we see fusion beats or not? Well, as you go across the rhythm strip at the bottom, you see that you have an utterly constant RR interval. So you're not seeing any differences in timing that might have helped you there uh, regarding ectopy or and so forth. Um, Now, if you take a look across at the morphology going across the rhythm strip, so one lead across the whole thing, yes, admittedly, there are differences in the morphology, but they are arguably subtle. So if you compare the second beat that I'm highlighting here to the fifth beat here, yes, you can make an argument that the um, the peak is less tall and that the relationship in heights between uh, the different deflections is a little bit different, but you see that there's a smooth rather than a sudden transition, right, as you go across. And I'm not seeing any sudden changes. And as you go across, you see that the QRS morphology kind of changes in this gradual fashion as you go across. And you see you go through these transitions one, two, three times maybe on this strip. And based on the timing and the smooth nature of this, you could even make an argument that what you're looking at is respiraphasic differences. But let's jump into what I mean exactly by fusion beats on the next slide. So this is an old slide provided by my former fellowship director talking about different levels of fusion with ventricular beats. So this is a person with sinus rhythm in whom ventricular ectopy is happening. And you can see varying levels of collision between ventricular beats and supraventricular conduction. So starting with the number 7, here you see a very wide QRS complex of a bizarre ST segment and an inverted T wave. This is what you might consider to be the most quote unquote pure version of a PVC, meaning it's coming in relatively early with respect to the prior beat, and it's looking very different from the surrounding sinus beats. Uh, then going to 5, you see uh, a wide QRS complex with that same ST segment depression and the inverted T wave, but you see how the beat is a little bit narrower. It's maybe just slightly less notched, and you see how its appearance is just one step closer to that of the flanking sinus beats. So this represents some degree of collision between the PVC and the supraventricular conduction, and it makes sense based on what you see here in that you see how the PVC in number 7 is happening right on top of the P wave and before that supraventricular uh, depolarization had a chance to conduct to the ventricles, whereas in 5, uh, it had a chance, the supraventricular beat, notably the sinus beat, did have some chance to travel to the ventricles. And it could be that the PVC is happening just on time as the ventricles are depolarizing due to the sinus beat. Then you go over to beat number 4, where the QRS complex is happening just a little bit early with respect to the sinus beat. So here you see it's, not quite 4 boxes between the P wave and the beginning of the QRS. Here it's more like 2.5, right, for beat number 4. And so the PVC is happening just a little bit later with respect to the P wave. The ventricles are having more of a chance to conduct from the sinus node. And as a result, you get an even more narrow QRS complex. It's a little shorter, that notch is gone, and so forth. Then you go to beat 3, where the PVC happens even later still, and you see this progression towards a narrower and shorter QRS complex. And then you get um, to beat number 2, where you're starting to see that the height of the QRS complex is pretty much the same as that in the sinus beats. It's just a slight bit longer. And then you get down to number 1, where you've got maybe evidence of a PVC coming in just because that tail of the QRS complex is not exactly like it is in the adjoining sinus beats, meaning instead of that J point that's down at the isoelectric interval or even slightly below, you get this shoulder, right, that's just above. But aside from that, the rest of the QRS complex, axis, height, width, etc., is effectively identical to that of the adjoining beats. And so this is one where the supraventricular conduction won, so to speak, and number 7 is where the ventricular conduction won. And as you can see here, beat to beat, you see a very sudden change, right, in the morphology. So you're not expecting to see this sort of gradual change that could be respiraphasic and could be a function of just change of the position of the heart with respiration, change of the position within the chest, thus changing the vectors with respect to the placement of the leads on the surface of the chest, which don't change with respiration. So the question here is, do we see any fusion beats? Not really. Do we see any of those sudden changes in morphology that we saw um, in the last slide? We really don't. Yes, we see these gradual changes, but you see how the overall complex, it looks pretty much the same, right? Um, you have a Q, you have an R, and you have an S here. And they're looking pretty much the same, even though the amplitude is a little bit different going across. And again, you see this smooth transition. So no fusion beats. So because we don't see any fusion beats, we don't really have any proof that this is ventricular tachycardia. Therefore, we move to the items in the Brugada criteria, which will serve to help give us a sense of what our index suspicion is that this would represent ventricular tachycardia versus supraventricular tachycardia with aberrant conduction. So the first is, do you see the absence of an RS complex in the precordial leads? Well, so going to V1 here, you see a Q, an R, and an S. And so this is looking like, although it's wide and otherwise normal morphology for a QRS complex. So the answer here is no. How about the R to S interval in the precordial leads, meaning going from peak of the R to the S? And as you can see here, it's pretty small, right? Anywhere you have an R to S, it's within one small box, so not only is it not less than 100 milliseconds, it's really not clearly more than 40 or 50 milliseconds. So here, once again, the answer is no. How about AV dissociation? Well, when I started, I talked about some of these notches in the rhythm strip that could ostensibly be P waves, right? This here, this, that one, that one. Some notches happening just after the QRS complexes, some happening just before. And if you take a look at these, and so the question is does this represent real atrial activity? And is it a stable rhythm that's truly dissociated from the ventricular rhythm? And in this case, the one thing you can do to ask uh, that question is to check the timing between the atrial activity that you suspect you see and see if it's consistent, and ask yourself, is there truly a rhythm present or not? And in this case, without using calipers, I'd say the answer is no, meaning it's not possible to go between these deflections, which are suspected atrial activity, and confirm that you've got consistent timing beat to beat. And as a consequence, uh, for all we know, these are either PACs that are happening or ventricular beats with variable uh, retrograde conduction times to the atrium, or this just could be noise. These could just be notches that don't represent atrial activity at all. But certainly nothing there that clearly demonstrates AV dissociation. So the answer there is no. How about morphology criteria, meaning a clear right bundle branch morphology in V1 or a clear left bundle branch morphology? And once again, we can take a look at V1 and V6, both of which are visible here. And in V1, you're seeing a QRS complex. We're not seeing a clear right bundle branch block pattern here, right? We're not seeing a double spike um, or a double R, like an R and R prime. And we're also seeing Q wave, meaning so we're not seeing the absence of a Q wave in V1. So no clear right bundle branch pattern. And taking a look to V6, is this a left bundle pattern? Well, you do not have a wide slurred QRS complex that is all positive, right? So absence of any Q wave and all positive in V5 and V6. And if anything, if you take a look at the lateral precordial leads, the predominant direction of the vector is negative. So we have no morphology criteria either. So we're kind of striking out here. And that's one of the points of this case, to show you that these challenging cases are going to come. And all you can do is to be systematic and be ready for the fact that you may not get as much help as you would like from the published criteria. And you're just going to have to look for things that the patient gives you that are maybe unsuspect, that you didn't expect, and maybe things that are not written in the textbook that'll help you out. So again, no fusion beats and the Brugada criteria not clearly met here, but we still have this wide complex tachycardia in a person who certainly is at risk for having a ventricular arrhythmia, right? He has documented coronary disease. His EF is depressed. It's not markedly depressed, but it's slightly depressed, and he has known ventricular scar, right, at the apex. And when you think about the morphology here, you're negative in 2,3 and AVF. So it's a formal possibility that that scar, which is at the apex or at the bottom of the heart, if you will, um, could, if this is VT emanating from there, it would be going from the bottom to the top, right? Therefore, the axis would be negative in the inferior limb leads. So this morphology is not unexpected for a ventricular arrhythmia coming from towards the apex. So what argument can you make for SVT with aberrancy? Well, we tried to assess whether or not this really represents an SVT. It's tough to know if it is or it isn't. We tried to look at those notches and figure out if they represent a real consistent supraventricular arrhythmia. We've got no evidence of that. And so the next question is, could this be another type of supraventricular arrhythmia, such as an atrial tachycardia with a very diminutive P wave, or could it be a junctional tachycardia, or even an atrial flutter with in a diseased atrium um, uh, without any obvious flutter waves? You can have that. This person does have a documented history of atrial fibrillation, so it's altogether possible that this person has a flutter. This person has not undergone an ablation procedure, therefore, um, and I mention that just because it's often the case that you'll see these atypical flutters without any clear atrial electrical pattern in people who have undergone an ablation of some type in the past, where there's enough scarring and enough structural change in the atrium such that uh, atrial activity can be masked or not clearly visible on the surface ECG. Last question is this atrial fibrillation? We know that the person has that. Is this atrial fibrillation? Well, if you take a look with calipers going across the rhythm strip at the bottom, um, the RR interval is utterly constant across the tracing. And as you all remember, in the context of atrial fibrillation, what you're expecting to see is nearly continuous variation in the RR intervals, consistent with the inundation of the AV node with the very rapid and rather chaotic electrical activity found in atrial fibrillation. So this is not that. So uh, we're not seeing any obvious signs here, but one thing you can do is the following. Um, you can look for an EKG of the patient in sinus rhythm, and that's arguably the best thing you can do, because anytime you've got a wide QRS complex like this, the first thing you've got to ask is, what's the patient's QRS complex when they're in normal rhythm? Is this really an aberrant QRS complex for this patient, or is this just what they look like in sinus rhythm? So in this person's case, we were able to dig up um, a 12 lead ECG. This is not the greatest reproduction, but you know how it is. You get what you get in these cases. And this is the best we can get from an outside hospital of this patient in sinus rhythm. So looking at the rhythm strip, you see that it's clearly sinus rhythm. The person has a long PR interval, so evidence of clear first degree AV nodal block. But if you take a look at the inferior limb leads, you're seeing that they're negative in 2, 3, and AVF the same way that they were in the tachycardia. You see that the QRS complex is wide the same way it was in the tachycardia. So then you can ask yourself, okay, am I seeing any difference in the width, or am I seeing any more subtle variations in the QRS complex? Well, here's a picture of the tachycardia just for your reference, and you see that in the inferior limb leads is not looking very different in tachycardia versus in sinus rhythm. In the anteroprecordial leads, it's looking different, right? You see this QR complex without an S in the anteroprecordial leads, but when you go lateral to the lateral precordial leads, you see how V4 has a very similar appearance, but you see this subtle difference in the notching, right? V5 and V6, although from a distance they may look very similar, there are some variations. Even in V4, the notching is different. So you can make an argument that in the anterior precordial leads, although the overall axis is very similar and the overall morphology is similar, there are clear differences. Whether this represents just rate-based aberration versus a true ventricular arrhythmia, or even just change in the placement of the leads is very difficult to know. And as you remember, uh, it's often the case that the anterior precordial leads are placed in the most variable positions, right? There's always going to be some variability in how these things are placed between patients and even in the same patient on a different day by a different technician, et cetera. They may be placed in a different spot, which may lead to some of these variations in the QRS complex. So it can be a non-specific finding, but definitely worth looking into. So here, if I had to summarize in one sentence what I think is happening is I think that the QRS complex looks very similar to the way it does. Uh, the QRS complex in sinus rhythm looks very similar to the way it does in tachycardia, although there are some variations in the QRS morphology, most notable in the anterior precordial leads in the tachycardia. So what are some other possible explanations for this? Is this ventricular pacing? I haven't said anything about a pacemaker in this patient, and they didn't tell us much about anything there. And it's always possible that a pacemaker is in place, especially these days if you have no chest X-ray yet. And I didn't mention anything about an X-ray for this patient yet. And it's not necessarily the case that the person will come in with a conventional system. It could be that this person has a leadless system, right? That won't leave any superficial marks. So the question is this ventricular pacing? Well, then the next follow-up question would be, okay, if it is ventricular pacing, what are you expecting to see? And that leads us to the next question. And so that is, are you expecting to see negative QRS complexes in the inferior limb leads, or are you expecting to see a right bundle branch block or left bundle branch block? And in general, what you're expecting to see is a negative complex in 2, 3, and AVF, like I said, going from bottom to top, right? And it should be a left bundle branch block because if you're pacing in the RV, you're going to block in the chamber of destination. So if your wavefront starts on the right and goes to the left, you're going to have a left bundle branch block. And so what you're expecting to see is negative 2, 3 in AVF and a left bundle branch block. And this is just an X-ray of somebody who got a pacemaker after a TAVR procedure to show you the location of the pacing lead in the apex of the right ventricle and why you would expect to see uh, negative complexes in the inferior limb leads as well as the left bundle branch block because you're in the RV, so you're going to go from right to left. That's going to give you your left bundle branch block. And as you can see, instead of the signal wavefront going from the top of the heart to the bottom, you're going in the opposite direction. So you're going to be negative in the inferior limb leads. And here's a clear case of ventricular pacing, right? You see the pacing artifact across all leads in the context of sinus rhythm. This is not this patient, incidentally. But somebody with sinus rhythm, first degree AV block, uh, or higher grade AV block in whom there's consistent ventricular pacing all the time. And you see how you have negative QRS complexes in 2, 3, and AVF. And if you take a look across the precordium, you see evidence of a pretty clear left bundle pattern, meaning completely negative QRS complex in V1, completely positive QRS complex in V6. So is that what we saw in our patient? It's really not, right? Even though there is a net negative vector in the inferior limb leads, you see that little R wave up ahead, right? So this is not bottom to top conduction. And like we talked about earlier, there's no evidence of a clear left bundle branch morphology. So in this patient, just to be complete about our thinking, there's no evidence of ventricular pacing because again, a wide QRS complex, even with tachycardia, two native explanations, meaning is it ventricular tachycardia or is it supraventricular tachycardia with aberrancy? Or lastly, is it not the person's own rhythm at all? And are they just pacing from the ventricle? Well, no clear evidence that this is ventricular pacing either for this patient. So going back now, which of the following is the most likely explanation for the wide complex tachycardia in this patient? Is this supraventricular tachycardia with aberrancy? Well, you know, so what are the items that we observe that are in support of this assertion? You have a QRS complex in sinus rhythm that's quite similar to that in tachycardia, with the exception of some changes in the precordial leads, which for all we know could be secondary to rate-related aberrancy, right? But tough to know. One of the things going against supraventricular tachycardia here is that we can't really identify definitive supraventricular tachycardia. It's not like we see no evidence of P waves. There's something that may be some atrial activity. It's very variable. And certainly there's nothing that we see there that represents true supraventricular activity that is conducting in a reliable fashion to the ventricles. So we don't have good evidence for that. Ventricular tachycardia, well, we see no fusion beats, right? And the Brugada criteria were not met, right? So those are items going against ventricular tachycardia. Um, Pardon me, I'm just getting a message here. Um,
And while Dr. Ptaszek is checking his page, does anyone have any questions so far on what we've covered? Feel free to reach out in the chat, raise your hand. We can give you ability to speak if you want to contribute anything at all. I really like this deep dive into really assessing where the arrhythmia is originating. It's really helpful, and I think it's something that we don't always do. We just see a fast beat and just trying to go with our best guess. So it's nice to have this you know a formulaic way of looking through it.
yeah, again, I think the more systematic you can be, the better off you're going to be. Because let's face it, when you're reading an EKG, there are numerous opportunities to fail, right? You're looking at a very complex phenomenon, something that represents very uh, complex electrical conduction, and every finding has multiple possible explanations, and you're expecting yourself to do it many times per day and to do it really fast, right? And it's not necessarily a setup for success. It's easy to miss things, it's easy to be inconsistent, etc. So for that reason, when I'm reading EKGs, I try to do things the same exact way every single time. It means that in some cases you may go a little slower than you might have. It means in some cases that you may go a little faster than you might have. But it allows you to be consistent, meaning you'll be efficient as you can be, and maximize consistency. So here, going to the next, thanks for being patient there. So no clear evidence that we have a supraventricular tachycardia. And is it aberrancy? Maybe, but it's tough to prove. Ventricular tachycardia, we don't have fusion beats. We don't have the Brugada criteria met. But here's one non-EKG item that will force you to consider ventricular tachycardia as an option, and that is this is a patient with known ischemic heart disease, right, with a reduced ejection fraction. So um, this is a person with a high pretest probability of having ventricular arrhythmias. So if you've got a wide complex tachycardia and you can't make a visual ID based on the EKG, you've got to incorporate non-EKG findings, notably the patient's history and the findings on the non-invasive studies, right? That'll really help you give you an index of suspicion. So even though the EKG is not telling us anything very definitive, and even though as you take a look, there's no evidence that this is ventricular pacing either, right? So even though the answers to number one and number three are no, and for number two, we don't have a clear yes, but based on circumstances alone, we've got to be suspicious of ventricular tachycardia. So knowing only that which I've presented to you here, if I were to force you to choose one of these, it would have to be VT, just because of the patient's circumstances and clinical history. So sometimes the patient gives you a gift. And this one does, because this is a case, of somebody with metastable VT. Uh, People are going back and forth. There's a lot of discussion as to what this could be, what this could not be, etc. But here is just a tracing of V1, lead 2, and an A-line tracing in the tachycardia to start. Remember, you have the Q, the R, and the S complex in V1, and in lead 2, you got this deep S with that little R notch, right? So here's this patient motoring along in tachycardia about 140 beats per minute, which is exactly where he was to start. and then boom, everything changes, right? You go back to two of those beats where you're clearly in sinus rhythm, right? You see a P wave, you have a QRS complex. The timing between the P and the QRS is clearly different between the two. And here you see after this beat, after the sinus beat, how much taller the pressure spike gets, right, on the A line. So this is clearly something that makes the patient much happier. And then just after that, you go back into the tachycardia. And here you can actually trace out the P waves. It could be that this little notch in the beginning of the QRS complex here, that actually is a P wave. Then you have a P wave here, and right on time is your next P wave. And here you have a P wave, but then you have that QRS complex happening just afterward. And if you take a look, it's pretty dominated by the ventricular morphology. There's no obvious fusion here. It just goes right back into the VT. So this type of change in morphology and a flipping of the axis is something that's highly unlikely to be due to simply rate-related aberrancy. When you're looking for rate-related aberrancy, you're looking for a complex that's largely the same. It's just a more sluggish or a slurred version of the same thing. Um, and the question here is, does changing the paper speed help? It can, but I would say um, probably the findings you're looking for, they should be sufficiently obvious. Uh, and I personally would say that, when you're dealing with a potentially unstable patient, I'm often working to try to keep things more simple for myself rather than more complicated. Everybody's clinical circumstances are going to be different. And if you're in control of the EKG machine and you could do it by yourself very quickly, then absolutely do it. But if you're in a setting like mine where, you have less control over how these things are done, et cetera, it may be one additional step that distracts you from how the patient is doing. So you'll have to decide whether or not change in paper speed helps you out. It's certainly a good possibility. It's not something I routinely do just because where I work, it would be number one, difficult for me to do, and number two, uh, may distract me. Um, and so here, based on this difference between what are clearly sinus beats and what are the tachycardia, this actually helps us make the decision that this is ventricular tachycardia. Um, and so to go back then to summarize what we've discussed so far, um, when you're looking at the EKG, trying to figure out whether or not a wide complex tachycardia, whether it's ventricular arrhythmia with aberrant conduction, whether it's true ventricular arrhythmia, or if it's ventricular pacing, first off, look at the patient, right? See how stable they are or not. Uh, Number two, look for fusion beats. If you have them, then that's the strongest indication that what you're dealing with is a ventricular arrhythmia. If you don't have fusion beats, you can use the Brugada criteria to look at the QRS complexes to assess whether or not you've got any features that increase your index of suspicion that it's a ventricular arrhythmia. And then last, you can look into other signs of a ventricular origin, like pacing or subtle changes in the gas complex, like we saw in this case. Um, and that's really what I had today. There's a question in the chat. How do you figure out whether or not somebody needs an ablation or not? I think it's a good question. And that is a more complex decision-making process that I did not include in today's session. For today is really just about um, a basic guide to patient evaluation and ECG evaluation, trying to just make the diagnosis. So this is really about diagnostics more than anything else. But regarding ablation, some general things you can think about, versus uh, medical therapy, you can take a look at the patient's structural substrate and assess whether or not you've got any evidence of structural abnormalities, potentially in the area where your ventricular arrhythmia could be coming from. So in this person's case, you've got that inferior scar and you've got that QRS complex that looks like it's coming from close to the apex of the heart, maybe even close to the conduction system. Um, so you've got a physical substrate, which medications may help uh, alleviate, but it's not going to fix the structural issue, right? So I'd say the places where ablation is the most obvious next step include number one, ventricular tachycardia that's not tolerated by the patient, meaning they get hypotensive or they're having syncope, right? Or if the person's got structural heart disease that's exacerbated in the context of ventricular arrhythmia. Or if you've got other reasons to believe that medications are not going to work, either because they can't tolerate them because of other types of conduction system disease, um, or if you see findings like in this one that you think, you know what, this could be something coming from close to the conduction system, and I'm worried that this is going to persist even with medications. Uh, Having said all that, even if you are in a position where you're thinking that an ablation is the most uh, appropriate thing to do for the patient, meaning uh, concern about heart failure and structural substrate and ability that the medications are not going to be well tolerated by the patient, and an observation that the arrhythmia is not well tolerated by the patient. So all these things are pushing you towards ablation, but it doesn't mean that you can't treat with antiarrhythmic drugs in anticipation of uh, the procedure. Um, and so you it's no matter where you are, it takes some time to arrange for an ablation, and maybe that you need to do some additional testing to make sure that the ablation is something that's appropriate for patients. So, number one, doing a further ischemic evaluation, make sure that they don't have a newly blocked coronary artery that could be either related to increase in the arrhythmia burden or might even make an ablation procedure more dangerous for them, right? So, ischemic evaluation may be appropriate in that circumstance. Um, and but even then, and even if you're waiting on the result of the studies, and perhaps especially if you're awaiting the results of the studies, or you may be in a place where you've got to make a hospital transfer or wait for the operator to become available or something like this. In many of these circumstances, you don't want to just leave the person in VT, right? Especially if they're hypotensive and symptomatic, et cetera. And so just because you're treating with medicines doesn't mean you've decided that's the most optimal treatment for the patient long term. So even if you've decided you're going to do an ablation, it's often the case you're going to temporize them with with an antiarrhythmic. And so that's really what I have for today's session. I appreciate your attention, I'm happy to have the opportunity to join all of you as part of this lecture series. And with that, I'll pause and ask if there are any additional questions that any of you have.
Thank you so much for that, Dr. Ptaszek. And if anyone has any questions, just raise your hand in the chat. We can give you permission to speak, or you can reach out into the chat and just let us know if you have any questions. And then in the meantime, do you mind giving me permission to share here? I'm going to switch over. Actually, I might be able to do it myself, but
I can just stop my sharing. Did that work?
yeah, it should do. There you go. Oh, so while we wait, feel free to ask questions. Which screen? Are you seeing my screen now here?
I can see your screen. Yeah.
Okay, perfect. So, yeah, I did a pretty bad job of introducing your organization at the very beginning. So, I just want to give you the opportunity to talk about the Boston Cardiac Foundation. But for those who don't know, we have formed a, new organization called the Global Cardiovascular Collaborative, where we are bringing together programs across the world that work to support the growth of cardiovascular care, whether it is electrophysiology, interventional, basic cardiology, as well as ACLS, BLS, and cardiothoracic surgery. So we're always looking for new organizations to get involved. We're looking for new programs that we can help support around the continent. So please reach out if you have any questions. We just wanted to show you some of the stuff we've done year to date. This is not a comprehensive list, but if you see here in February, um, our friend Dr. Ptaszek actually went to Meerut, India, who I'm sure you could talk a little bit about it. But did you have anything you wanted to contribute about the Boston Cardiac Foundation? If not, here's some details on them. But Leon, I don't know if you had anything to add. I kind of put you on the spot.
No, no problem. So it's an organization that was founded by Salil Midha a number of years ago. He's been active in this space for decades. Um, and I think he has leveraged his personal connections in northern India to increase capacity for EP care there. So that has meant going now for almost 30 years, um, every year to both New Delhi and Meerut to provide pacemaker implantation in people who can't pay for it themselves. And the program actually led to the establishment of an independent site, meaning one of the places where, you know, BCF was the first group to put in pacemakers in Meerut, and now the hospital where they were, um, uh, they're now doing them themselves. And so we visit every year, we provide intraprocedural proctoring and so forth, but they're doing over 100, 150 devices on their own and with very good quality. So it's sort of an indicator of what can happen with longitudinal presence, with consistent teaching, consistent providing of not just resources like pacemakers, gloves, sterile gowns, sheaths and the rest, but also your presence to teach them, et cetera. And actually, during this last trip, is very gratifying to see the progression in that of the 20 cases we did, I was only asked to do two. And because the team was doing them on their own, I was standing right behind them and offering them, proctoring and the rest. But the two cases that I was asked to do involved people with adult congenital heart disease, so people with VSDs, ASDs, and the like. And these are cases that they never would have taken on in that hospital, even last year. So it's just a nice example of what you can grow into if you're present over a long period of time and you're consistent.
It's amazing. And yeah, I think that's really a testament to, the support that the BCF have done, as well as to the program in Merit to become self-sustaining and really sharing that knowledge. So I really do appreciate you giving some insight there. Lastly, just to update you, we will be attending the following conferences. So if anyone is going to be at ACC, Cardiotan, Africa STEMI, HRS, please reach out. There's a lot of opportunities to collaborate. We'll have representatives at all those conferences and probably more. We just don't even know it yet. So we hope to see you there. Do we have any more questions in the chat at all? Let's see. Saw something pop up. Do we offer training to nurses who are specialized in cardiovascular care, working together? We do. So whenever we go on a trip, for example, we just had a team go to the Gambia, and we brought a full team of a physician, nurse, as well as two physiologists and a radiology technician. And the idea is that you're able to exchange knowledge and train and learn with your counterparts from around the world. So there is opportunity when we're in the field. There's also opportunities at a lot of these upcoming conferences. So, for example, Africa STEMI conference, There's a lot of opportunities for those in the cath lab and EP labs, and to train. Same thing at Cardiotan. So I would say reach out about those. Make sure to register for Africa STEMI. We and the Dennis and Jane Rees Foundation have actually offered a grant to cover registration for folks. So when you register, make sure to apply for that grant as well to hopefully get your registration covered. It's a limited supply, so I can't guarantee everyone will get their registration covered, but it does help defer the cost of these conferences, and I can tell you it's definitely worth your time. So make sure to check those out. Anyone want to speak? Let us know. If not, you enjoy the rest of your Sunday.
All right,
Thanks,
everyone. Have a good
AJ.
one.
Thanks, Leon.
Thanks.
Great talk.
Thank you again, Leon. That was fantastic, and we'll talk to you all soon.
All
Have a
right.
great
Have a
day.
good one.
Thanks.
Thanks again.